A massive postpartum hemorrhage is a high-speed emergency. In a massive bleed, the traditional slow approach of trying one drug, waiting to see if it works, and then trying another costs lives. This flowchart outlines the modern clinical response. Guidelines require a bundled, simultaneous approach that moves systematically through 3 phases: medical, mechanical, and surgical. You have to beat the clock. Before initiating any intervention, you need a reliable baseline alert. We use the shock index, calculated by dividing the patient's heart rate by their systolic blood pressure. A resulting value greater than 1.0 is the definitive indicator of active, severe hypovolemia. Recognizing this mathematical red flag early gives the clinical team the precise signal to immediately trigger the medical bundle. In obstetric hemorrhage, time saved is tissue saved. Let's apply this to a clinical scenario. A multiparous patient has just delivered, but her uterus remains soft and body, and she continues to bleed heavily. As part of your first response bundle, what is the correct administration protocol for tranexamic acid, or TXA? The strict protocol requires administering 1 gram of IV TXA immediately. Then, if the bleeding persists at the 30-minute mark, you must repeat another 1 gram IV dose. Running a 2-gram continuous infusion fails to deliver the rapid plasma concentration needed for an acute hemorrhage. Oral TXA has 0 role in emergency resuscitation due to slow absorption times. Crucially, this TXA protocol is not a standalone step. It must be executed simultaneously alongside aggressive uterine massage and the administration of oxytoxics. Executing this pharmacological strike as a single bundle is the only way to rapidly induce clotting and contract the uterus before the patient enters refractory hemorrhage. Now assume 30 minutes have passed. The medical bundle has failed, and the uterus remains completely atonic. Of these 4 options, a Bakri balloon, a B-Lynch suture, an artery ligation, or a hysterectomy, what is the immediate next step you can perform right at the bedside? The correct answer is the uterine balloon tamponade. By filling the balloon with sterile saline inside the uterine cavity, it exerts outward hydrostatic pressure directly against the bleeding vessels, arresting the hemorrhage from the inside out. Students frequently select surgical compression, like a B-Lynch suture. That is incorrect for this stage. Compression sutures require an open abdomen and a fully equipped operating theater, making them impossible to deploy in a standard labor room. The balloon also acts as a diagnostic tool called the tamponade test. If heavy bleeding continues to leak around the inflated balloon, it provides a definitive clinical signal that you must transfer the patient to surgery immediately. But what if this happens in a rural primary health center, and the patient requires transport to a tertiary hospital? Here, you use the non-pneumatic anti-shock garment. It tightly compresses the lower body, forcing blood volume back up into the core organs and actively reversing hypovolemic shock during transit. Whether you are deploying a balloon in a delivery ward or a compression garment in an ambulance, these mechanical interventions provide the vital physical bridge to keep the patient alive until surgical control is possible. In our final escalation, the patient's estimated blood loss has reached 2,000 milliliters. The team must aggressively manage a collapsing coagulation cascade. Fibrinogen is the first coagulation factor to crash during massive bleeding. Trigger aggressive replacement the moment levels drop below 200 milligrams per deciliter. Waiting for levels to fall below 100 is a dangerous misconception indicating late-stage disseminated intravascular coagulation, which carries high mortality. Modern massive transfusion protocols require a strict 1:1:1 ratio, 1 unit of packed red blood cells, fresh frozen plasma, and platelets. Pumping patients full of clear crystalloids washes out clotting factors, directly causing the lethal obstetric triad: acidosis, hypothermia, and coagulopathy. We can summarize the entire management protocol. Watch for a shock index over 1.0. Administer your TXA and uterotonic simultaneously. Use balloons or compression garments as a mechanical bridge, and run a balanced 1:1:1 transfusion. Mastering postpartum hemorrhage requires anticipating the next phase before the current one fails. Bundle the medical strike, bridge with mechanical pressure, and replace clotting factors equally to outpace total system failure.